This is again Professor Triple N or PA Nick from Brooklyn, New York. This is my second part 2 of Pulmonary PANP board review notes. If you have any questions, please feel free to email me to my email, which is very simple. NICK, M like Mary, D like dog, number 1 at gmail.com. Let's start from slide number 2. Slide number 2 talks about cystic fibrosis. Cystic fibrosis by etiology and definition. This is autosomal recessive disorder, which is caused by mutation in the genes that code the chloride transport. This is known as so-called CFTR or cystic fibrosis transmembrane conduction regulator. The mutations of CFTR gene usually damage the chloride and water transport across the apical surface of the epithelial cells of the exocrine glands throughout the body. This leads to abnormal thick mucus in the lungs, as well as damage of the pancreas, liver, sinuses, intestine, and GU tract. They're clogged up. The damaged mucus clearance decrease the ability to get rid of inhaled bacteria. Here there is a clinical tip which states that neutrophils in CF dump tons of DNA into the airway secretion, clogging them up. How the cystic fibrosis presents. 1/3 of CF patients are adults. Look for young adult with chronic lung disease, which complains of cough, sputum, hemoptysis, bronchiectasis, wheezing, and dyspnea, and recurrent episode of infection. Sinus pain and polyps are very common. We need to remember that there is a clinical tip here which states that the lung disease accounts of 95% of death of patients with cystic fibrosis. Let's talk about GI involvement. Usually, patient presents with meconiomyelitis in infants with abdominal distension. This is number 1. Number 2, pancreatic insufficiency in 90% with steatorrhea and vitamin A, D, E, K malabsorption. Number 3, recurrent pancreatitis. Number 4, distant interstitial obstruction due to biliary cirrhosis. Let's go to the next slide, which is slide number 3. This slide discusses GU involvement of cystic fibrosis patient. But before that, we have a clinical tip which states that inlets are spared, better cell function are normal until much later in life. So let's discuss GU involvement in patients with cystic fibrosis. The men are usually infertile. 95% have azoospermia, in which the vas deferens is missing in 20%. Wow. Women are infertile because of chronic lung disease, alter the menstrual cycle, and thick cervical mucus blocks the sperm entry. The diagnostic tests which are used here in this case, the most accurate test, this is increased sweat chloride test. Pure carpine increase the acetylcholine levels, which increases the sweat production. Chloride level in sweat, it's above 60 milliequivalent per liter. On repeat testing will establish the diagnosis. Also, we can do genotyping with CFTR, which is not very accurate, but we will find increased sweat chloride level also. So remember, genotyping for CFTR gene. And this is because of there are so many different types of mutations leading to cystic fibrosis. Additional tests here are chest X-ray and CT. There is no single abnormality on imaging of the chest which can confirm the diagnosis of cystic fibrosis. The findings are the following: bronchiectasis, pneumothorax, scarring, atelectasis, and the last one is hyperinflation. Also, the arterial blood gas may show hypoxemia. In advanced disease, it may show respiratory acidosis. PFT also shows mixed obstructive and restrictive patterns, and also decrease in FVC and total lung capacity, and decrease diffusing capacity of carbon monoxide. Also, the sputum culture shows Haemophilus influenza and Pseudomonas aeruginosa. Let's go to the next slide, which is slide. Also, we can discuss the very big area, a new clinical topic for pneumonia. And the first one, this is community-acquired pneumonia. By definition, community-acquired pneumonia, or CAP, is defined as a pneumonia which occurs before hospitalization or within 48 hours of hospital admission. This is the definition: before or within 48 hours. CAP is the most common infectious cause of death in the United States, and this is among the top 10 causes of death nationwide. Etiology is that strep pneumo is the most common cause of CAP. Neither the environmental reservoir of strep pneumo or its method of acquisition. Let's go to the next slide. In slide number 5, we can see the most common pathogens of CAP and their associations. COPD patients usually have the pneumonia is caused by Haemophilus influenza. For Staph aureus is associated with recent viral infection. Klebsiella pneumonia is associated with alcoholism or diabetes. Anaerobes is associated with poor dentation and aspiration. Number 4, Mycoplasma pneumoniae is usually in young, healthy patients. Chlamydia pneumoniae is usually associated with hoarseness. Legionella is associated with contaminated water sources, air conditioning, and ventilation systems. The other bacteria, which is Chlamydia psittaci, is usually associated with birds, and Coxiella burnetii is associated with animals at the time of giving birth, veterinarians, and farmers. How this pneumonia presents? Usually, all forms of pneumonia presents with fever and cough. Severe infection is associated with dyspnea. Cough from any etiology can be associated with hemoptysis. Dullness and percussion is found if there is no infusion. Bronchial breath sounds or agophony occur from consolidation of air spaces. Severe infections are distinguished by abnormalities of vital signs, which is tachycardia, hypotension, tachypnea, or the mental status. So if we have tachycardia, hypotension, and tachypnea, or altered mental status, this is considered severe forms of CAP. Also, we can find on auscultation, rales, rhonchi. Let's go to the next slide, number 6, crepitations, which are frequent auscultatory findings on virtually any form of lung infection. Abdominal pain and diarrhea may occur with infection in the lower lobe. Chills or rigors are a sign of bacteremia, frequently with bacterial pathogens. Chest pain occurs from inflammation of the pleura. Hypothermia is just as bad as fever in terms of pathologic significance. Chest pain from pneumonia are often pleuritic and changing with respiration. There is a clinical tip here which states that on the PANP boards exams, you may play abnormal breath sounds as part of multimedia, and you could be asked to recognize them. There is another clinical tip here which states that dyspnea, high fever, and abnormal chest X-ray are the main ways of distinguishing pneumonia from bronchitis. Also, there is organism-specific associations or presentations. Klebsiella pneumonia is frequently associated with hemoptysis from necrotizing disease with current jelly sputum. Anaerobes is frequently associated with foul smell sputum and rotten eggs. Mycoplasma pneumonia frequently associated with dry cough and rarely severe bullous meningitis. Legionella is associated frequently with GI symptoms such as abdominal pain, diarrhea, or CNS symptoms such as headaches and confusion. Let's go to the next slide. Slide number 7. And pneumocystis is usually associated with AIDS with CD4 cell count less than 200. Infections are often accompanied by a dry, non-productive cough, such as mycoplasma, viruses, Coxiella, pneumocystic, and chlamydia. All these infections preferentially involve the interstitial space and more often leave the air space in when the alveoli are empty. That is why there is less sputum production. Specific sputum columns are useless in determining the etiology. Also, there is a diagnostic test, and the best initial test for all respiratory infections are chest X-ray. It is a chest X-ray. The X-ray, however, cannot determine the specific etiology. So we need to do is a sputum gram stain and sputum culture, which is the best way to try to determine a specific microbial etiology. Unfortunately, many organisms will not be detected by the sputum stain or culture. The term atypical pneumonia refers to an organism which are not visible on gram stain and they are not culturable on standard blood agar. The use of sputum stain in culture is somewhat controversial because they have low sensitivity. Even after throughout sputum examination, no etiology is found in at least 50% of the cases. This is because of mycoplasma, chlamydia, Legionella, Coxiella, and viruses are not visible on gram stain, and these are 50% of the cases of CAP. Leukocytosis, which is elevated white blood count, is frequently presented, but is a non-specific marker for infection. Let's discuss here infections which are often accompanied by dry, non-productive cough. Number 1, this is mycoplasma. Number 2, viruses. Number 3, Coxiella. Number 3, pneumocystis. And number 5, chlamydia. All these infections preferably involve the interstitial space and more oftenly they leave the air spaces of the alveoli empty. This is why there is a less sputum production. Specific sputum colors are useless to determine the etiology. How we diagnose this? The best initial test for all respiratory infections are chest X-ray. The X-ray cannot determine the specific etiology. The sputum gram stain and culture are the best way of first trying to determine the specific microbial etiology. What is the term atypical pneumonia means? This is referred to organisms which are not visible on a gram stain and they are not culturable on standard blood agar. Basically, even after through sputum examination, no etiology is found in about 50% of the cases. This is to determine that because of mycoplasma, chlamydia, legionella, and coxiella, and the viruses are not visible by gram stain, and this is about 50% of the cases of CAP. And as we know, we can find leukocytosis or elevated white blood count often presented in these cases. But this is not specific. Let's go to the next slide. Next slide on figure 6-4 shows a right middle lobe infiltrate, which is characterized by bacterial pneumonia. We have on the lower part, right middle lobe infiltrate consistent with bacterial pneumonia, and we have minor fissure which separate the middle from the upper lobes. So basically, a chest X-ray can be, we can see a bilateral interstitial infiltrate, and it is seen in cases of mycoplasma, number 1, number 2, viruses, number 3, coxiella, number 4, pneumonia, and number 5, chlamydia. These are the same organisms which are typically presented in non-productive cough. X-ray lag behind the clinical finding. So there is two clinical tips here, which is that the first chest X-ray can be falsely negative, at least 10 to 20% of the cases. And number 2, the sputum gram stain is adequate if there are more than 25 white blood cells in fewer than 10 epithelial cells. Let's go to the next slide. On this slide, which is number 9. Number 9, on figure 6/5, shows the interstitial infiltrate, which leaves air space empty. The chest X-ray can be consistent with PCP, mycoplasma, viruses, and chlamydia. Also, we can do is chest CT on an MRI, which shows greater definition of the abnormality found on a chest X-ray, but it will be still not able to determine a specific microbiological etiology. There is here another clinical tip. Which states that the infectious diseases, the radiological test is never the most accurate test. Then we have blood cultures which are positive in 5 to 15% of the cases of CAP, particularly in strep pneumonia. There is a specific, another clinical tip here which states that it is impossible to make specific diagnosis of the cause of pneumonia from history and the physical. The test can be done in severe disease with unclear etiology or those which are not responding to treatment. Also can be done thoracosynthesis, which is analysis of the pleural effusion, which sometimes can be useful for determining of the presence of the empyema if the diagnosis is unclear. Any new large effusion could be analyzed. Emphysema is of the infected pleural effusion. Empyema act like abscess and will be improve more rapidly if it is drained with the chest tube. So empyema, if we have empyema, we need to look for LDH above 60% in the serum level and proteins above 50%. Let's go to the next slide. Slide number 10 discuss when we have WBC above 1,000/1 microliter or pH less than 7.2 is suggestive of infection. A clinical tip here states that new large effusions secondary to pneumonia should be tapped. There is here on this slide number 10 some information for bronchoscopy. Bronchoscopy, this is rarely needed in cases of CAP. But can be used in case of severe disease such as someone which needed to be placed in ICU when initial testing such as sputum stain and culture and blood cultures do not determine the organism and the patient condition is worsening despite the empiric therapy. An exception is pneumocystic pneumonia, which is non-invasive testing, a rare review of diagnosis, and precise confirmation of the etiology is critical to guide the therapy. Let's go over a table which shows specific diagnostic tests by organisms. If we have a mycoplasma pneumonia, we need PCR, cold agglutinin, serology, specific culture media. If we have chlamydia pneumonia, then we need we'll see a rising of the serological titers. If we have Legionella, we need to do urine antigen culture or of charcoal yeast extract. If we have a case of chlamydia psittaci, we will see a rising of the serological titers. If we have a Coxiella burneii, we'll see a rising of the serological titers also. If we have a case of if we have a case of PCP or Pseudocystis juveki, we need to have bronchoalveolar lavage or BAL. In case of mycoplasma and chlamydia, we rarely confirm because of they are simply treated empirically. If we have patients with mycoplasma or chlamydia, they are very rare and rarely confirm because of they are simply treated empirically. And slide number 10 finalized that mycoplasma and chlamydia are rarely confirmed because they usually are treated empirically. Let's go to the next slide. So the treatment of this type of pneumonia is it is rare to have a specific organism identified at the time of the treatment. And if the case presents described organism on gram stain, then the treatment needs to be directed towards the organism. Usually, the most important step of initial management of pneumonia is to determine the severity of the disease in order to determine the location in which to place the patient. It is the severity of disease, not the etiology, which drives the initial therapy. So let's talk about outpatient, vice versa, inpatient treatment. When we do outpatient treatment, previously healthy patients or no antibiotics in the past 3 months and mild symptoms, we give microlights like azithromycin or clarithromycin or doxycycline. Comorbidities, number 2, comorbidities on or antibiotics of the last 3 months, we give respiratory fluoroquinolones such as levofloxacin or moxifloxacin. When we do inpatient treatment, when we have a respiratory fluconazole, levofloxacin or monofloxacin or ceftriaxone and azithromycin, and this is the patient which needs inpatient treatment. Also, there is a clinical tip which states that all infections, almost all infections are initially treated empirically, that is, without a specific etiology. Let's go to the next slide. Next slide talks about, on figure 6/6, talks about outpatient treatment of community-acquired pneumonia, CAP. On the left side, we'll see these differences. On the left side, we have a previously healthy or no antibiotics in the last 3 months or mild symptoms. So we give microlights, azithromycin or clarithromycin or doxycycline. On the right side, we have comorbidities on antibiotics in the last 3 months. We give respiratory fluoroquinolones such as levofloxacin or moxifloxacin. There is difficult reasons for hospitalizations, but the most important are hypoxia and hypotension are single factors which are the reason to hospitalize a patient. So if the patient is hypoxic or hypertensive. In 80% of the cases, patients with pneumonia can be safely treated with as an outpatient with oral antibiotics. Severe disease can be defined as a combination of hypotension, systolic less than 90, number 2, respiratory rate above 30 per minute, or PO2 less than 60, or pH 7.35, elevated BUN above 30, sodium less than 130, glucose above 250, pulse above 125, confusion, temperature above 104 Fahrenheit. And if the patient is, let's go to the next slide. And if the patient is older than 65 or comorbidities such as cancer, COPD, CHF, renal failure, and or liver disease. Also, we need to notice that the chest X-ray does not guide the admission. Chest X-ray cannot tell the severity of hypoxia. And here we have a clinical vignette which states that 65 years old a woman is admitted to the hospital for CAP. Sputum gram stain shows gram-positive diplococci, but the sputum culture does not grow any specific organisms. Chest X-ray show lobar infiltrate and large effusion. She's placed on ceftriaxone and azithromycin. Thoracentesis review elevated LDH and protein level of over 17,000 YWBCs per microliter. Blood culture grows Streptococcus pneumoniae with minimum inhibitory concentration to penicillin less than 0.1 microgram per milliliter. Her oxygen sat is 96, BP 110/70, temperature 102, and pulse 112. What is the most appropriate next step of management of this patient? A. Repeat thoracentesis. B. Placement of chest tube for suction. C. Adding ampicillin for the treatment. And D. Place patient in intensive care unit. And E. Consult pulmonary for the patient. We have so-called CURB 65 admission, which C stands for confusion, U like uremia, R respiratory disease, BP will be low, age will be over 65. The right answer here is that is B. When we have infected pleural effusion or empyema, which respond most rapidly to drainage by chest tube and thoracentesis. A large effusion acts like abscess. It is hard to sterilize. Each side of the chest can accommodate between 2 and 3 liters of fluid. There is no benefit of adding ampicillin or ceftriaxone. If it is a low MIQ to penicillin, automatically means that the organism is sensitive to ceftriaxone and in fact all cephalosporin. There is no need to be in ICU just because of effusion or for chest tube. Chest tube drainage. Let's go to the next slide. I'm sorry. If the patient is not stable and despite the effusion has no evidence of instability because of her pulse is only mildly abnormal and the blood pressure and the oximeter are normal. Pulmonary consult is not adding anything, so you don't even try to call a pulmonary doctor. Let's talk about exudate, vice versa, transudate effusions. Pleural effusion with pH less than 7.2 suggests for empyema it needs a chest tube drainage. LDH over 60 for serum 0.6 or protein more than 50 of serum 0.5 suggests for exudate. So LDH over 60 in the serum or 0.6 and protein over 50 of the serum 0.5. This means exudate. Exudates are frequently caused by infection or cancer. CURB 65 0/1 means home, more than 5 points, admission. On the figure 6/7, we see pleural effusion with large minuscule sign. Only a fluid sample from the thoracentesis can determine the specific cause. Consultation is never the right answer for PANP board examination. Let's go to the next slide, 15. On this slide, we see on figure 6/8, effusion, which is freely mobile and form of layer when the patient lies on her side. On figure 6/9, we have hydropneumothorax of both abnormal air and fluid effusions in the pleural space. Chest tube drainage is the most effective because this can resolve this condition. Let's discuss the pneumococcal vaccination. Everybody which is above age of 65 should receive vaccination within 13 polyvalent vaccine for 6 to 12 months within 23 polyvalent vaccine. In addition, those with chronic heart, liver, kidney, and lung disease, including asthma, should be also vaccinated as soon as possible. The underlying disease is apparent regarding age. Other reasons for to vaccinate are the following. Number one, let's go to the next slide. This is slide number 16. Functional anatomical asplenia. Example, sickle cell disease. Number two, hematological malignancy, leukemia, lymphoma. Number three, immunosuppression, diabetes, alcoholism, corticosteroid use, AIDS or HIV. And the last one is CSF leak and cochlear implant recipients. Those which are generally healthy should receive a dose of age of 65. First, initially use 13 and then 23 vaccine in 6 to 12 months. If the first vaccine was given before age of 65 or within other conditions previously described, a second dose should be given 5 years after the first dose. Healthcare workers do not need pneumococcal vaccine. Let's pause for a second. We're back again in business. Let's talk about health-associated pneumonia or hospital-acquired pneumonia. HEP or hospital-acquired pneumonia is defined as a pneumonia which develops more than 48 hours after admission or after hospitalization in the last 90 days. These patients have a much higher incidence of gram-negative bacilli such as E. coli and Pseudomonas as a cause of their infection. The main differences in management is macrolides such as azithromycin or clarithromycin, which are not acceptable as an empiric therapy. Instead, treatment of HIP is centered around the therapy for gram-negative bacilli such as anti-pseudomonal cephalosporin, cefepime, or ceftadine, or anti-pseudomonal penicillins like piperacillin, tazobactam, or carbapenems like imipenem, meropenem, or doripenem. Piperacillin and ticardocillin are always used in combination with the beta-lactam inhibitors such as tazobactam or clavulanic acid. Let's go to the next slide, which is slide number 17. Let's discuss so-called ventilator-associated pneumonia. Mechanical ventilation interferes with normal mucociliary clearance of the respiratory tract, such as the ability to cough. Positive pressure is tremendously damaging for the normal ability to clear the colonization. VAP or ventilator-associated pneumonia is with big incidence is as high as 5% per day in the first few days of the ventilation. What is the most likely diagnosis if they ask this question? Because of the multiple concurrent illnesses such as CHF, even a diagnosis of VAP can be hard to establish. We need to look for fever or rising of the white WBCs. This is number one. New infiltrate on the chest X-ray. 3, purulent secretion coming from the endotracheal tubes. The diagnostic tests for VAP is because of the colonization of the endotracheal tube, ET, sputum culture is nearly useless. The diagnosis of specific etiology is extremely difficult on a ventilator. The following tests are given in order from least accurate but easy to do, the most accurate but most dangerous. Number one, tracheal aspirate. A suction catheter is placed into the ET and aspirate the content below the trachea when the catheter is in past the end of ET tube. Number two, BAL, B-A-L, or bronchoalveolar lavage. Bronchoscope is placed, which to be put deeper into the lungs where there is not supposed to be any organism. Can be contaminated when passed through the nasopharynx. Number three, protected brush specimen. The tip of the bronchoscope is covered when passed through the nasopharynx, then uncovered only inside of the lungs. Much more specific because of a decreased contamination. So-called video-assisted thoracoscopy or VAT. A scope can be placed through the chest. Let's go to the next slide, slide number 18. Through the chest wall, and sample of the lungs can be taken biopsy. This allows a large piece of lungs to be taken without the need to cutting of the chest open or thoracotomy. It is like sigmoidoscopy of the chest. Number 6, open lung biopsy, the most accurate diagnostic test of VAP, but with much greater morbidity and potential complication of the procedure because of the need of thoracotomy. On figure 6/10, we see subcutaneous subcu emphysema is the air normally leaking into the soft tissue of the chest wall. Chest tube placement may cause air leak into soft tissue of the chest wall. Cutting of the endotracheal tube is like cutting urine with a Foley catheter in place. It will be always gross sometimes because of the colonization. The treatment. The treatment is a combination of 3 different drugs. Anti-pseudomonal beta-lactams like cephalosporins like ceftazidime or cefepime, or let's go to the next slide. Slide number 19. Penicillin, which is piperacillin with tazobactam, or carbapenem, imipenem, meropenem, or doripenem. Plus, number 2, we have a second anti-pseudomonal agent. Aminoglycosides with a gentamicin or tobramycin or amikacin, or fluoroquinolones like ciprofloxacin or levofloxacin, plus methicillin-resistant anti-staphylococcal agents like vancomycin or linezolid. There is no need for daptomycin for lungs. Daptomycin is inactivated by the surfactant. And there is another clinical tip which states here that change of the initial therapy for VAP is needed if specific etiology is identified. And here we have a clinical vignette to discuss, which states that the patient is admitted to the hospital with head trauma and subdural hematoma. Patient is intubated for hyperventilation and possible craniotomy. Several days after the admission, the patient started to vomit blood and found to have stress ulcers of the stomach. Lansoprazole is started, VAP developed, and the patient is placed on imipenem, linezolid, and gentamicin. Phenytoin is started prophylactically. 3 days later, creatinine levels are rising. Patient then starts having seizures. Repeat CT of the head shows no changes. The question here is, what is the most appropriate next step of management? Number A, switching phenytoin to carbamazepine. B, stop lansoprazole. C, stop imipenem. D, stop linezolid. And the last one is it's hard to understand, but anyway, the right answer here is C. Imipenem can cause seizures. Imipenem is excreted through the kidney. The renal failure had caused to rise in imipenem levels, leading to toxicity. This is much more likely than failure of phenytoin. Let's go to the next slide. Slide number 20. We'll discuss so-called lung abscess. Lung abscesses. By etiology, lung abscesses are rare because of prompt treatment for aspiration pneumonia. A lung abscess occurs only in a patient with large volume aspiration of oropharyngeal content, usually poor distension, who is not treated sufficiently. A large volume of aspiration occurs from aspiration pneumonia in the upper lobe when patient is laying flat. So aspiration pneumonia occurs in case of stroke with loss of gag reflex, number 1. Number 2, seizure intoxication. Number 3, endotracheal intubation. If question is asking what is the most likely diagnosis, we need to look for a person with one of these risk factors, presenting a chronic infection developing over several weeks of a large volume sputum, then in 4 swelling because of anaerobes. Weight loss is common. Diagnosis and treatment: chest X-ray is the best initial test and will show cavity, possibly with air fluid level. Chest CT is more accurate than chest X-ray, but only a lung biopsy can establish the specific microbial etiology. Clindamycin or penicillin is the best coverage for lung abscess. Sputum culture is always the wrong answer for diagnosis of a lung abscess. Everyone's sputum has anaerobes from the mouth floor. Let's go to the next slide. which is slide 21. In figure 6/1 /11 and figure /12, we'll see a cavity consistent with the abscess in a thick wall and air fluid level. Let's talk about another clinical category, which is pneumocystis pneumoniae. Etiology, agent causing PCP has been renamed P. girovesi instead of P. carini. PCP occur almost exclusively in patients with AIDS, which CD4 cell count drops lower than 200 and who are not on prophylactic therapy. Which is the most likely diagnosis? Look for patients with AIDS presenting with dyspnea on exertion, dry cough, and fever. The question is often suggesting or directly state that CD4 count is lower than 200 and the patient is on prophylaxis. Diagnostic tests, the best initial diagnostic test, this is a chest x-ray which shows a bilateral interstitial infiltrate or arterial blood gas looking for hypoxia or increased A/A gradient. LDH levels are always elevated. Most accurate test is bronchoalveolar lavage. Sputum stain for pneumocystis is quite specific. If this is positive, if the stain is stated to be positive, there is no need for further testing. A negative sputum stain means you should answer bronchoscopy as the best diagnostic test. Bronchoscopy. This is the best diagnostic test. Let's go to the next slide. Next slide, there is a clinical tip. This clinical tip states that the normal LDH means that you should not answer PCP as the most likely diagnosis. You can distinguish PCP from mycoplasma, chlamydia, or viruses by X-ray alone. You cannot distinguish. However, in HIV, PCP is the most likely with interstitial infiltrate. There is another clinical tip which states that remember that the questions on the PANP boards are asking that you are the most likely diagnosis, not is the most likely diagnosis. So basically, if the question asks what is the most likely diagnosis, not what is the most sure diagnosis. That's a very good clinical tip. The treatment is with trimethoprim sulfamethoxazole is unquestionable the best initial therapy both for treatment and prophylaxis. You add steroids to decrease mortality if PCP is severe. Severe PCP is defined when the PO2 is less than 70 or AA gradient is above 35. The medication, which is called atovaquone, can also be used as an alternative to trimethoprim sulfamethoxazole if the PCP is mild, meaning there is only mild hypoxia. If there is a toxicity from trimethoprim sulfamethoxazole, switch the treatment to either clindamycin and primaquine or pentamidine. Let's go to the next slide. In this slide on a figure 6/13, we'll see another example of bilateral in, interstitial infiltrate. Here we have a clinical vignette which discusses a situation with HIV positive African American man, which is admitted with dyspnea, dry cough, high LDH, and PO263. He was started on trimethoprim sulfamethoxazole and prednisone. On the third hospital day, he developed severe neutropenia and rash. He had anemia, and then on a blood smear was seen bite cells. The question is, what is the most appropriate next step of management of this patient? Number A, stop the trimethoprim sulfamethoxazole. B, begin antiretroviral medication. C, switch trimethoprim sulfamethoxazole to IV pentamidine. D, switch trimethoprim sulfamethoxazole for aerosol pentamidine. The answer here is C. The rash is the most common side effect of trimethoprim sulfamethoxazole, and bone marrow suppression is the second most common side effect. So the right answer here is C. Although clindamycin and primaquine may be more efficient than pentamidine, the patient seems to have a glucose 6 dehydrogenase deficiency or G6PD deficiency, and primaquine is contraindicated in G6PD deficiency. He is an African American man, and there is bite cells suggesting for G6PD deficiency on his smear. For active disease, IV pentamidine is used, not aerosol. Starting IV medication should be done eventually, but they will not help an acute opportunistic infection. In addition, antiretroviral are relatively contraindicated in acute opportunistic infection because of the possibility of immune reconstructive syndrome. 24. Often students will see two correct treatments and think there is a mistake in the question. If there is two correct treatments, look for the contraindication of one of them. Let's talk about PCP prophylaxis. We need to start to prevent PCP on this patient with AIDS, which CD4 count is below 200, with number 1, trimethoprim sulfamethoxazole. If there is a rash or neutropenia from trimethoprim sulfamethoxazole, you use number 2, atovaquone or dapsone. Aerosol pentamidine is not used as second-line therapy for prophylaxis because of it has less efficiency than either atovaquone or dapsone. And there is a clinical tip here which states that always choose therapy based first on efficiency, not side effects. You have to remember here that dapsone is contraindicated in this patient with G6PD deficiency. And this is the end of the lecture. Thank you so much. Once again, this is Professor Nick, NNN or Triple Nick or PA Nick from Brooklyn, New York. If any questions, please feel free to email me. My email is very easy, nickmd1@gmail.com. Thank you so much.